smell from the patient. Now, this is theoretical. A garlicky smell is not always present in the patient, but yes, a petroleum-like smell is definitely you can notice in practice in the organophosphorus toxic patient. In cases where there's no laboratory facilities or in doubtful cases, 1 mg of atropine can be given intravenously. And if that intravenous injection does not produce anticholinergic manifestations, then acetylcholinesterase poisoning should be strongly suspected.
We are the topic OP poisoning. Dr. Missy Bonsal from Kolkata EM Medical College. So we are discussing with the topic of the OP poisoning. Let us give a big round of applause to come and discuss with us a OP poisoning topic.
Hi Chandra. Let's start the topic. It's OP poisoning, myself by Nishi Agarwal. The overview of the presentation would be, first we'll look at the uses, then we'll go to the classification, the metabolism and the mode of absorption of organophosphorus compounds, the clinical features of the toxicity, their management, and what is the mortality regarding organophosphorus compounds. Here the introduction is there. OP compounds are chemical agents used worldwide, mainly in the agriculture sector. They comprise the ester, amide, and thiol derivatives of phosphoric acid, which is used as pesticides. They can also be used as nerve agents in the Tokyo War, that sarin gas. These are not only bad, they can be used as a therapeutic agent in treatment of glaucoma. Organophosphorus compounds have no rules and regulations for the purchase. They are available over the counter. The fun fact is, attempt to suicide is a more common cause of poisoning than the chronic exposure of farmers and the sprayers of pesticides. Based on according to their toxicity and the clinical uses, the organophosphorus compounds are classified to be highly toxic, intermediately toxic, and low toxic. The agricultural insecticides are considered to be highly toxic, whereas the household applicants, which are used for ant killers and the cockroach killers, are considered to be low toxicity. These are the ways the patient can get exposed to organophosphorus compounds. At home, there can be accidental ingestion, lawn and garden use, insect control, food supply, and water supply, which are contaminated by the crops which are spread by the insecticides and pesticides. Occupational exposure, the ones with the farm workers, the pesticide sprayers, the manufacturers, the mixing and handling people, and the landscapers. The other routes of exposure can be dietary, that is the pesticides which are not washed once the crops. Before consuming it, it should be properly washed, otherwise the pesticides stay over the crops, which is toxic. Leaching from the soil to the groundwater and community exposure. These are the absorption routes. Cutaneous, because the organophosphorus compounds are lipid soluble, thus they can cross the skin, the intact skin. Thus cutaneous becomes the most common route of absorption. Ingestion, either accidental or suicidal, inhalation and injection. Pharmacokinetics, most organophosphates are highly lipid soluble and well absorbed from intact skin and mucous membrane and can easily cross the blood-brain barrier, producing the potent effects in CNS, that is restlessness, anxiety, leading to coma, confusion. They are rapidly redistributed to all body tissues, highest found in liver and kidney. Metabolism occurs principally by oxidation in the liver with half-life of minutes to hours. The patient produces signs and symptoms within minutes to 3 to 4 hours, being an acute toxicity case. Elimination of organophosphorus compounds and its metabolites occur mainly via urine, bile, and feces. What is the mechanism of action of organophosphorus compounds? These compounds inactivates the acetylcholinesterase enzyme by establishing a covalent bond with the enzyme, after which the enzyme undergoes one of the following: either endogenous hydrolysis, reactivation, irreversible binding. Once the acetylcholinesterase activity is inactivated, it accumulates throughout the nervous system, causing overstimulation of muscarinic and nicotinic receptors. What are the clinical features of organophosphorus compounds? The toxic features are usually obvious within 30 minutes to 3 hours, Majority of patients give a history of intentional or accidental ingestion. The onset and severity of symptoms depend on the compound amount, route of exposure, and rate of metabolism. Early cases present predominantly with parasympathetic overactivity and a characteristic garlic like smell. Most fatalities occur within 24 hours of toxicity, and those who recover usually do so within 10 days. And if they don't, the end result may be a multi-system manifestation. These are the proper signs and symptoms of organophosphorus compounds. They act by three receptors being muscarinic, nicotinic, and central. The serious effects of organophosphorus compounds are it causes bradycardia, hypotension. In respiratory system, it causes rhinorrhea and bronchospasm. In gastrointestinal system, it causes nausea, vomiting, increased salivation, abdominal cramps, and diarrhea. Genitourinary system, there's urinary incontinence. In general, organophosphorus compounds increases the secretions from the body, leading to urinary incontinence, fecal incontinence, nausea, vomiting, rhinorrhea, lacrimation, salivation. In eyes, there's blurred vision and meiosis too. Via the nicotinic receptors, in the CVS, it causes tachycardia and hypertension. Musculoskeletal, there are weakness, fasciculations, cramps, and paralysis. Via the central receptors, it causes anxiety, restlessness, ataxia, convulsion, insomnia, dysarthria, coma, tremor, absent reflexes, respiratory depression, and circulatory collapse. WHO classification for the severity, WHO has classified organophosphorus toxicity to be mild, moderate, and severe. The patients with mild toxicity will present to you walking and talking with mild abdominal pain, nausea, vomiting, but increased salivation and sweating. There could be presence of headache. The moderate severity patients will talk in a soft voice, will be hesitant on walking, and restless and anxiety present. Fasciculations could be present, and there will be meiosis. Now, the severe toxicity, the signs and symptoms shown are coma, confusion, profuse bronchial secretions, may lead to aspiration too. Now, the first part of management is the diagnosis. The diagnosis, the proper hints which are given by the patient for which will lead towards the proper diagnosis are garlicky smell from the patient. Now, this is theoretical. A garlicky smell is not always present in the patient, but yes, a petroleum like smell is definitely you can notice in practice in the organophosphorus toxic patient. The history of exposure and characteristic signs and symptoms of organophosphorus compounds will be present. Patient attendant found poison container in the vicinity of the patient. Cholinesterase enzyme estimates are the only useful biochemical tool for confirming the exposure. In usual hospital settings, the cholinesterase enzyme biochemical tool is not regularly used. Overall, the enzyme activity even does not correlate with the clinical severity. The signs and symptoms are the major clue and the hints which lead to the proper diagnosis. Analytical identification of organophosphorus compounds from the gastric aspirate or the body fluids gives the clue of exposure. However, in places where there is not no laboratory facilities or in doubtful cases, 1 mg of atropine can be given intravenously. And if that intravenous injection does not produce anticholinergic manifestations, then acetylcholinesterase poisoning should be strongly suspected. Now we'll go to proper treatment. This is the overview of the treatment. First of all, we need to decontaminate and support the patient, block the muscarinic activity, which is the life-threatening cause in organophosphorus compounds. Reversal of cholinesterase inhibition, correction of metabolic abnormalities, prevention of infection, and management of complications. While supportive therapy, a comatose or a vomiting patient should be kept in a left lateral position. This is to prevent aspiration. Patent airway should be secured. Intubation should be necessitated if the patient is unconscious or is having seizures. Frequent suction of the oropharyngeal secretions because there's increase in salivation and rhinorrhea present. The need for oxygen shall be assessed by the practicing doctor. All the clothings and the hair accessories shall be removed and placed in appropriate waste bags. The patient should be washed with copious amount of soap and water. Long hairs and fingernails should be carefully washed. These are the two main modalities when a patient comes to the hospital with organophosphorus toxicity. First one is gastric lavage, and the second one is activated charcoal. Gastric lavage is considered if the patient comes within 1 to 2 hours of ingestion. Now, this gastric lavage has its own complications, which includes aspiration, hypoxia, and laryngeal spasm. Activated charcoal, this reduces the poison load by absorbing the organophosphorus compound over the surface of the charcoal. A single to multiple dose has been used in clinical practice, which is 25 mg 2 hourly. Avoid cathetics and induced emesis. Induced emesis is avoided in any poisoning case in general. Now, blockade of muscarinic activity. This is the main modality of treatment in organophosphorus compounds toxicity. The specific antidote which blocks the muscarinic activity is atropine, thus reversing the life-threatening features. There are three regimes for administering atropine IV, but the gold standard which is used nowadays is the incremental dose regime, in which the dose is incremented from 2 mg to 4 mg, then 8 mg, then 16 mg, and so on until we attain a target point and atropinization is confirmed. Then the infusion to maintain the target level is given. Now, how will you know that atropinization has occurred? These are the signs and symptoms. That is increased body temperature, dry axilla, heart rate and blood pressure both will increase. There's dilated pupil and clear chest on auscultation. Now, you have to be careful about atropine toxicity. Over atropinization may necessitate discontinuation of atropine infusion. Glycopyrrolate. This is recommended when there is copious secretions and there is atropine toxicity with the presence of CNS poisoning. The dose of glycopyrrolate be 7.5 mg glycopyrrolate in 200 ml of saline started as infusion and is titrated to the desired effects of dry mucous membranes. Oximes. Now, this is one of the medicines which are used in organophosphorus compounds. How does that work? As we all know, organophosphorus compounds binds with the acetylcholinesterase irreversibly and inactivates the enzyme. Oximes work by reactivating the acetylcholinesterase that has been bound to the OP molecule. Now, pralidoxime is the most frequently used oxime worldwide, the dose of which is 30 mg per kg bolus IV over 20 to 30 minutes, now which is followed by infusion of 8 mg per kg per hour. Rapid administration can lead to tachycardia, laryngospasm, muscle spasm, and transient neuromuscular blockade. Mortality. Worldwide mortality is 2 to 25%. Now, this mortality varies. It depends on the type of compound used. It is highly toxic, intermediately toxic, or low toxic, as according to the classification of organophosphorus compounds. The amount of compound ingested, the general health of a patient, whether the patient is suffering from CKD or some other liver disease, the metabolism is affected and thus the mortality rate. Delay in discovery and transport. This is considered a point while chronic organophosphorus poisoning in farmers and pesticide sprayers. Insufficient respiratory management, delay in intubation, or failure in weaning of ventilatory support. These are few mortality related rate on which mortality depends. So this is all about organophosphorus compound.